So we have a little bit of leisure time now to walk through what is actually a fairly complicated space that Ralph and I would like to simplify so that people can take something that is quite complicated and we walk away with some concrete points. So next slide, please. So just to get started, if you're a patient with AML or a caregiver, has mutation testing been done for you or the person that you're taking care of? This is kind of graduate level question. Do you even know what we're talking about? Yes, no, not sure. Okay, so we have 65% yes, which is a lot. Next, next slide, please. There's one more question. And how long did it take? Do you guys know how long did it take for you to get the mutation results back? Under a week, a couple of weeks, 3 to 4? Any idea? One to 2 or 3 to 4 weeks. So it still takes a while, and I'm going to we're going to talk about that a little bit. But let me get to my first slide, please, because I'm actually going to step backwards and say we've just spent, so we have almost, I don't know, 17 minutes on the clock already. And we've had 3 letters stated over and over again, AML, AML, AML. What is AML? So acute, Ralph said it already. Acute means it's something doesn't hang around for very long. It moves quickly. Myeloid is taking you to an organ that most people don't realize is an organ, and it's a vital one at that, bone marrow. Some of you may imagine a dog bone. You've got the hard part on the outside, the soft part on the inside. That is bone marrow. It is the factory that makes your blood cells, white blood cells that fight infection, red blood cells that carry around oxygen and give you energy, platelets, little tiny cells that swim around and help you stop bleeding or clot if you get a cut. And the bone marrow is a vital organ. I say this all the time and people are surprised. They don't think of it that way. You think of your heart as a vital organ. The neurosurgeons, of course, think the brain is a vital organ. I ask them, what is the actual point of having a brain if there's no blood supply to your brain? I always win that argument. It's a vital organ and you can't live without it. And if you look at the slide in front of me, SEER is just how we look at epidemiology of diseases in the United States. So this is a rare one. Look, 1, 2, 3, breast, prostate, lung, all the way down way at the bottom with 20,000 cases as opposed to hundreds of thousands of cases is AML. It's the most common acute leukemia in adults, but still is a rare disease, not in my office, as Ralph will tell you, but it is a rare disease. But have a look at this chart on the right. So this is our good news chart. Things are getting better. Survival is better. But did you guys in the audience catch what Ralph said 10 years ago, 2014? So I got a big hug actually on that anniversary. He and I like that anniversary. But he wasn't being told about 10 weeks or 10 months of survival at the time when we started talking about this in 2014, let alone 10 years. And even today, finding people, it's not to reveal people's ages on webinars. I never do that because he might reveal mine. But 10-year survival is something that is still a lot more rare than what we would like it to be. Next slide, please. Now here are the toys. So if you look at my toy slide, these are a bunch of names and the target that they hit biologically, and I'm not going to go through all of them, but this is a stunning slide because of the title. So 2017 to the present. What did Ralph say? We're all the way back in 2014. So we had, and Charlie and I sadly are both old enough, I guess it beats the alternative, but we're both old enough to say that certainly when I became an attending physician in 2000, I didn't have good toys at all. We hadn't been able to get anything approved in AML. There has been a literal explosion of novel therapies with major, major changes in the standard of care and in what we are able to offer patients. That was a fire lit in 2017. And this is actually, and the top somehow got on the bottom here, which I didn't catch, but the top one on the list is actually, so this is going backwards in time, all the way back to 2017 were the initial kickoff here. And I have to say that Ralph got in early on this action in 2014. So when he's talking about his time and starting all of this, we had had one after another of failures to help patients in AML. The clinical trials weren't going very well. And it was a really big deal for him to get onto a clinical trial at that point. And he started talking about things, waiting a couple of weeks for results, having me call him to get onto a clinical trial. That was a crazy conversation that I still remember to this time. But what he was facing down, and I have to tell you, and Ralph's going to be mad at me at this, what he described to you was awful, and he went through awful stuff. And his journey is his experience. But what I was seeing in the hospital and what I was seeing for other patients, believe it or not, was way, way worse and more horrifying than what he went through. And he did this because he has the most amazing family in the world. They possibly are on the webinar. So hi, guys. But he did this as an outpatient, not admitted to the hospital with horrible complications and the intensive care unit. And Ralph, don't be annoyed with me for saying, but with everything that you went through, we just couldn't believe it. You were on a pill that was transforming leukemia cells in front of us in labs, and you weren't in the hospital hooked up to all kinds of horrible things that didn't work. So you did beat out, even with everything that you went through. You launched a revolution, and this man is on the front cover of the drug company that happened to make the drug that he was on. It was a revolution. Are you mad at me now for saying all of that? It's not to minimize your suffering in any way. I just think it's important for people to understand how much actually worse it could have been, which you can't imagine, but I really can. Are you mad?
No, I'm grateful.
Okay, he's not mad at me. So I got through slide 2 without him being mad at me. Go to the next slide, please. I'm going to do a tiny bit more biology. Nobody can read this slide. That was my point of putting it here. When you sit in the waiting room in Charlie's clinic or in my clinic, everybody might have AML on a particular day. And yet it's kind of like saying at this point, I'm sick. It doesn't tell us enough. There are so many aspects of the biology of AML that can be messed up that in 2025, what we are able to do, not perfectly, but way better than before, is actually figure out where you are in this complicated pie chart. What kind of things and all of these letters and things that I'm not going to teach today, but the biology of what goes wrong in AML is a lot. Sometimes more than one thing goes wrong, and then you need a combination of therapies together. But this pie chart now isn't just a science project. It's directing us in 2 ways that are incredibly important, both prognostically and therapeutically. And I think that part of the reason why we're here today is to get everybody to start asking the questions of, well, wait a minute, what type of AML do I have? Where am I on this pie chart? What do you have for me that might be directed specifically as opposed to generally? And these are questions that have really changed the entire therapeutic landscape of AML and truly change what patients are going through in that we are able to, much quicker than we used to, get information back that directs us either to specific therapies that are available or to clinical trials, which are still the #1 answer for many, many patients with this disease. And we're going to talk about that, why it's important to know about clinical trials. Ralph has benefited actually from 2, because in the middle of things, he didn't tell you, we haven't been hanging out doing the same thing for 10 years. There have been changes along the way. There is a new therapy along the way, and there's actually a whole bunch of different testing, which he likes to be on the forefront of. And he'll let me do things like bring him back in for another bone marrow biopsy, which is not so much fun, but to make sure that he's still on the cutting edge. Can I do something better or different after all of this time. And Ralph just did that, right? We dragged you back in for another bone marrow biopsy, even though you didn't need it, but just to make sure that could I be doing anything better with medication that you're currently on? Comments,
Well,
anger.
how nice it is that I haven't been forgotten. I don't see you as much as I used to, which is good, but I know that you still care about me and think about keeping me going.
And he came back in because he said, if you've got something good, maybe I want in on it. Next slide, please. So there are challenges that are faced here when you get a diagnosis of AML or candidly by any other diagnosis, right? So patients need to know, what do I actually have? What kind of tests could you do? How quickly can you get them back? Nobody likes to sit around waiting for test results. Doctors are actually the worst. I mean, we want the results back before they've even been delivered to the test center. Clear communication between physicians and patients, and also access to the testing methods. I'm always cognizant when we're on worldwide webinars that not everybody has access to everything. So the questions are, well, what do I really need? What could I get? Do I need to go somewhere? I mean, Ralph travels. He doesn't live in New York City, but he came here because his docs thought that we might have more here. Other people around the world might need to travel too. Is it worth the travel? Is it worth getting into a car, train, or a plane to travel for something? Next slide, please. This is a complicated slide which talks about testing methods. I'm not going to teach about testing methods, but it's meant to tell you that things like cytogenetics, karyotype, chromosomes, FISH testing, PCR testing, sequencing. There's all kinds of different tests that are getting better and better and more precise that go into the diagnosis. And patients can start asking, and this is really across oncology. So if anybody's on the line who has a different type of a cancer diagnosis, oncology is cutting edge. It's all about hanging out on the cutting edge. What tests do I need to tell me the most information from my doctor, both to say prognostically, how easy or how difficult is this disease to treat? And what type of therapy do I have that works? Or if it doesn't work, if the existing therapy doesn't work well, what could I possibly do to get to on a trial that might work better? The alphabet soup on the slides is difficult to go over in such a short period. The slides will be available, but these are tests that can actually be done worldwide. And there has been an incredible improvement worldwide in access, at least to the basics of what we need for AML diagnosis and prognosis. You don't necessarily need a panel of 200 genes to figure out what to do with your disease, but it might be awfully helpful to have 3 or 4. And there is a vast increase truly worldwide, even in resource challenged areas, of what can be done. And it's worth pushing that point. Next slide, please. So how do patients get access to this? So it's worth always, with anything, even if you're going in with diabetes or hypertension, ask the doc, how good are the therapies that you have for what I've got? And if I joined something, if I joined a trial, if I went somewhere different, would I be likely to get access to something new? Ralph actually, at the time of this, when all of this started in 2014, we didn't have regular access to this type of testing at all. It was very new. And a lot of times patients, even today, get access to more testing if they participate in a clinical trial, or alternatively, they may get faster results back. And in the United States and across Europe, there are certainly clinical trials in which if you're on the trial, you get the results back faster than if you were waiting in a doctor's office. So it's something that's at least worth consideration. Next slide, please. So do you actually know, anybody know what a clinical trial is, and have you ever participated in one? What the answer is to that. So that's about 50-50. And actually, I'm not sure I fully know that the people who said yes are right. And one of the things that I hear all the time is, oh, a clinical trial, that's a new drug. I don't want to get something new. I don't want to be a guinea pig. I don't want to be tested on. Clinical trial might have nothing to do actually with a brand new drug. Ralph's did. It was a new drug and new testing, but there are plenty of clinical trials that are just trying to make existing therapies work better without necessarily introducing something new. Next slide, please. So what are they? It might be, there's something new about it. It's a research study, new drug, new device, new treatment. We want to know if it's safe and we want to know if it works. And I've heard it all. I've heard patients come in, I definitely want the new drug. I want the new drug. You guys must know that the new drug is working better. I want that one. We don't know that. There are plenty of new drugs that don't work. In fact, too many of them that don't work. So when patients come in and say, well, I don't want to get the fake drug, I don't want to get the placebo, this is a test where I might get something that's a sugar pill. I have to say there's a lot of unanswered questions about clinical trials that you should dig into with your docs. How hard is it to be on the trial? Is it a new drug? Not all new drugs work. Is it likely that this one is going to hurt me or help me, or do you not know? Ralph, tell about your experience of me. And I was actually shouting at him because I got the results when I was at the top of a mountain. I was skiing and I screamed at poor Ralph and his family through my helmet microphone because we didn't have much time. The slots were going fast on the clinical trial, and I needed to know whether he wanted it. So when I shouted at you from the top of a mountain about a clinical trial, how crazy did you think I was, skiing aside?
Well, it was a difficult phone call, but who else would call me from her vacation in January? Finally got a little time off skiing and doing this tracking of one patient's testing, waiting for the test results, and then without being able to tell me to do it, you somehow got the message across that we had the choice. And I like to give you my opinion about the clinical trials that, yes, I didn't want the placebo, but that was a moment of selfishness. But I would say, in spite of the clinical trial administration being, let's just call it average, when I was in the clinical trial, the word that comes to mind is I was nurtured. Nurtured because I didn't know what was going to happen, but I knew what the process was. I knew where I was supposed to go. I knew I was being taken care of. I knew there was a protocol. So I think three of us on this call today are the biggest cheerleaders for clinical trials. I'm certainly one.
Charlie, I want to let you jump in here because I know you are super passionate about this topic.
Yes, I think, Gail, there are many reasons why opening up a broad trial portfolio is a benefit to patients. I think it does allow access to new therapies in the fastest possible way. But I think there are other aspects of this which are sometimes underestimated. Ralph's absolutely right that all the data in whatever disease shows that your outcome is better if you're treated on a clinical trial than not. That's true in arthritis, that's true in kidney disease. And there is something about the environment in which you enter around a clinical trial that is very important. And I think we also sometimes underestimate the value to patients of altruism. Altruism is a very powerful sentiment in all of us. I mean, it's the reason there are 45 million volunteer unrelated donors across the world who are signed up to give their bone marrow to somebody if they need them. And many patients find this really quite empowering. So those are the three other points I think that are worth bringing out, Gail.
No, I think it's an incredibly valuable thing to say. There are A clinical trial is about creating also, not only does the drug work or the therapy work, but it's about creating the package insert, right? If you're going on a drug, if your doctor gives you an antibiotic for something, you want to look and say, well, I don't know what's going to happen to me with this. Now, on the one hand, if you read the package insert of a Tylenol, you think you're going to die in 10 minutes. But on the other hand, what are the risks? What are the benefits? What does this do? How do we dose it? What are you doing? You're creating the package insert for the drug. You're creating something that not only is a benefit to you, but a benefit to somebody else. And I have absolutely had people say that, well, I really, really, really want this to work for me, but I sure hope that it can work for somebody else too. And Ralph is nodding. I think that knowing you for all these years, I know that resonates with you.
Yes, it certainly does. As I said, I was glad to get the drug, but I think as both of you are saying, it is quite often that people will say, "I'll do it." Maybe not for me, but for the next person. And boy, that's a credit to the human spirit.
And I
It's
suppose
also,
the
go
only
ahead.
other thing I'd add, Gail, and maybe I referred to it at the start when I was talking about Watson and Crick, is, we as a human society have invested trillions of pounds and dollars in development of these therapies. And there is some sort of moral imperative, I think, on clinicians, but also funders, to ensure that patients who really do need them, who have difficult diseases, can access clinical trials as a routine rather than just be, I was in the right place at the right time.
They're not all the same. And I think that when people say, well, oh, I do want to be on a trial or I don't want to be on a trial, don't do that. Specifics. What clinical trial? Which one for me, right? They're different. And I think it's very worth digging into the question. They're not all the same. It's not necessarily a new drug. It's not necessarily a randomized trial, which means that you might get one arm or another. There are lots of details. Don't make a quick statement that, oh, I would or would not want to be on a clinical trial. Get the details, and then you'll make a much better decision for yourself. Next slide, please. Do you know if your treatment was chosen based on a genetic mutation result? This is for anybody on is a patient or dealing with a patient. We'll see the results about that. So people know. I have plenty of patients, and this includes doctors too. You don't necessarily have to get in the weeds on everything. I have plenty of patients who say, hey, I'm coming to you, whatever you say is good, and they don't want to necessarily know everything. And then I have the opposite. I work in New York. Sometimes people are coming in with 4,000 pages printed from the internet with every single clinical trial. They already know where I got married. They know every detail about everything. It doesn't matter what works for you psychologically. You don't have to be the person who knows everything, and you don't have to be the person who knows nothing. But there are some questions that I think somebody around you as the patient or the patient might want to know. And that's, what do I have? How bad is it? How good is it? What do you have that is working for me? What do you have that is new for me? These are very basic. These are very basic questions. And I think if you look at the next slide, that's going to be my segue, I think, depending on what's coming. Oh, good. I did that right. So that was the segue to how do we do this together? So when we're making decisions together as the doc, are you the person who wants the 4,000 pages, doesn't want the 4,000 pages? So realistic expectations for treatment and recovery. Ralph, how do you do that? How do I do that when I'm putting you on a brand new drug? I could never say to you when you started what exactly this journey was going to look like, right? So realistic expectations, you knew that you had a very serious disease. The docs were telling you you might die a lot sooner than you wanted to. But how did we navigate that, realistic expectations and easier to follow the treatment plan? How did I do that since I didn't know what to tell you?
Well, that's a very interesting comment. I don't want to misinterpret it, but is it possible that I was guided by you into a clinical trial and that neither of us knew what would happen?
I think that that's kind of without having known what you would say. So I really like the idea of realistic expectations, treatment recovery, making it easier, improving the, results following treatments, the shared decision making, but the shared decision making is trust too, and getting the rapport. You learn about me, I learn about you, we get in this together and we understand that whether it's man plans, God laughs, or whatever your philosophy of life is, to realize that an AML diagnosis is a bumpy road and that the caregiving team needs to have a general plan for you that makes you feel very well taken care of, informed when you need information, but not deluged if you don't. That's, I think, an important balance, that sometimes too much information is overwhelming. So we have to meet you where you need to be, and to sort of tell each other how to develop a communication style so that you walk out feeling like you've had a positive visit. I want to give that back to you, Ralph, that other comments about this shared decision making.
Well, the fourth bullet here, helping patients feel more confident, independent, and in control. You made me feel that way. I would say I didn't feel I needed to be in control because I was lucky enough to have, as the local doctor said, an oncologist in a large organization with a lot of experience. So our communication was really good. But if you recall, I didn't maybe push back much because I was in your hands and I felt confident being there. So I think that's a plus. It's maybe harder for sometimes when a patient meets a doctor and that confidence doesn't come through so fast.
I think it's important to, you got to think that the bus driver knows where you're going, right? So I do think that sometimes, look, when there's an emergency and there's no choice, you can't necessarily fall in love with the care team. If there's an emergency, you kind of get what you get and you don't get upset. But if there is an opportunity to build a relationship or to have a care team that you're trusting, it certainly makes things much easier. And I think it's very important because these are long journeys. AML is a long journey, and it's a very high class problem when it's a long journey of 10 years. We like that, but it's important to have that relationship if you can get it.